Hello everyone, this is Dr. Madhusudan Rao. On the program I teach medical students. Today I briefly touch on Pons. Pons, as you know, is a component of the brain stem. And if you know the structure of the Pons, it's very easy to understand the clinical manifestations of various pontine syndromes. Pons, it has got the nuclei of the four cranial nerves. That is, fifth, sixth, seventh, and eighth cranial nerves. Just look at this picture. It shows the nuclei of the cranial nerves. If you take it from the medial to the lateral side at its dorsal aspect, you have got the sixth cranial nerve, you have got the seventh cranial nerve, and you have the eighth cranial nerve, and the most dorsolaterally, you have got the fifth cranial nerve. This is the tegmentum part of the pons. Well, if you go a little towards the ventral aspect of the pons, you have the pyramidal fibers. Okay? Depending upon the area of the infarct, you will get the clinical manifestations. And there is also sensory ascending fibers. That is, medial lemniscus, spinothalamic fibers. They are located towards the central part of the pons. So these are the various structures that are there in the pons, and the occlusion of the blood vessels supplying the pons will result in the clinical syndromes. What is the blood supply of the pons? Pons receives its blood supply through branches of the basilar artery. They are paramedial branches and the perforating branches of the superior cerebellar artery, and also some branches from the anterior inferior cerebellar artery. Then coming to the clinical manifestations of pontine lesion. It could be lateral pontine syndrome, it could be medial pontine syndrome, or it could be locked-in syndrome, or it could be ventral pontine syndromes. So the clinical manifestation depends on the part of the infarct that occurs in pons. Okay, and the structures that are involved will determine the clinical presentation. Like that, this is the ventral pontine syndromes, like the Raymond syndrome or Millard-Gobler syndrome. What happens in Raymond syndrome? This is because of the unilateral ventromedial pons infarct. Ventromedial part. What are the structures involved? It involves the pyramidal fibers and the fibers of the abscess. So it has got only two components, remember my students. It involves the pyramidal fibers and the fibers of the abscess nucleus. Abscess nerve, not the nucleus. So results in the contralateral hemiplegia with ipsilateral sixth nerve palsy. That's it. That is Raymond syndrome, one of the ventral pontine syndromes. Then the other one is the Millard-Gobler syndrome. What are the structures involved in this? It involves sixth and the seventh cranial nerve in its medial ventral pons. Okay? It involves facial, basically of the abscess and the facial nerve. Basically means fibers of the abscess nerve and those of the facial nerve. Okay? And the pyramidal fibers. So what could be the presentation? It results in the ipsilateral sixth and seventh nerve palsy with contralateral hemiplegia. It's very simple to understand, right? In the Raymond syndrome, there is involvement of the pyramidal fibers and the fibers of the sixth nerve only. Then in Miller-Gubler syndrome, there is seventh nerve is also affected in addition to the sixth nerve. Look at the picture here. Yes, this is the Raymond syndrome. This is the ventral part of the pons. Okay, where there are pyramidal fibers, and this is the sixth nerve fibers coursing close to the pyramidal fibers in the ventral part of the pons. So in fact, in this particular area, it results in Raymond syndrome, manifests as the contralateral spastic hemiplegia with ipsilateral sixth nerve palsy. In Miller-Gubler syndrome, it involves the facial nerve also. That results in the contralateral spastic hemiplegia with ipsilateral sixth and seventh nerve palsies. Okay, is it clear? Yes. Next is this is that one. Then you have got this is the medial pontine syndrome. Medial pontine syndrome is also called as Fowley syndrome. What are the structures involved? In this part of the pons, there are nuclei of the facial nerve, nucleus of the abscess nerve, and parapontine reticular formation, and medial lantern fasciculus and the medial lemniscus. So, in fact, involving these structures, the medial pontine syndrome will present as ipsilateral facial nerve palsy with ipsilateral abscess palsy and ipsilateral horizontal gaze palsy. Well, associated with contralateral spastic hemiplegia and hemianesthesia. Okay, this is the medial pontine syndrome. Okay, is it clear? That's what it is. Then coming to the lateral pontine syndrome. So what are the structures in the lateral part of the pons? You have importantly, there is two cranial nerves. One is the facial nerve and other one is the vestibulocochlear nerve, are located in the lateral part of the pons. Okay, towards the medial into the dorsal aspect, you have got the sixth nerve, and little laterally are the nucleus of the facial nerve and the vestibulocochlear nerve. So in the lateral pontine syndrome, seventh and eighth cranial nerves, along with the middle cerebellar peduncle and the pyramidal fibers are affected. This results in the contralateral spastic hemiplegia with contralateral hemianesthesia because of the involvement of the spinothalamic tracts, and also contralateral loss of pain and temperature sense. Okay, and ipsilateral limb ataxia along with the ipsilateral facial and eighth nerve palsy. Okay, with hearing loss, vertigo, and nystagmus. So these are the features of lateral pontine syndrome. So if you understand the structures in that part of the pons, say it is the lateral pons, or say it is the medial pons, say it is the ventral pons, you can easily understand the clinical manifestations of that particular syndrome. Okay, so that is the reason why anatomy or the anatomical structure of the neuraxis is very important for you, the students, to understand the clinical presentation. Okay? Say lateral pontine syndrome. I'll give you an example. The patient of 30 years who has been suffering from now and then the falls, attacks of falls, suffering from vertigo, okay, suddenly presented to you with the facial nerve palsy, with weakness of one half of the body, with loss of pain and temperature sense. So this clearly says the patient is suffering from the facial nerve, injury to the facial nerve, injury to the vestibulocochlear nerve, okay, and some cerebellar signs due to the involvement of the lateral cerebellar peduncle. So this is the way we have got to interpret the clinical signs of pontine injury. As a matter of fact, any neurological injury, either due to infection, either due to trauma, either due to ischemia. So, my dear students, it is very clear to you to interpret the clinical manifestations of pontine syndromes. So, you look at the pictures showing the site of infarct. This is the lateral pontine syndrome, the infarct involving the lateral part of the pons, with the involvement of the 6th and 8th cranial nerves and the pyramidal fibers and the cerebellar peduncle, etc. Then this is the picture of the medial pontine syndrome, otherwise called Fowler's syndrome. So you see the infarcted area. It is located more medially, involving the pyramidal fibers, okay, PPRF, 6th nerve nucleus, 7th nerve, and presenting with the and medial lemniscus. You will have the hemiplegia, hemianesthesia, and ipsilateral horizontal gaze paralysis, along with the facial nerve and the opposite nerve palsies. So, if you look at the picture, you can understand the clinical presentation of this particular individual. That is the Fowler's syndrome. Well, if you see the locked-in syndrome, because here the structures are involved bilaterally. So, bilateral pyramidal fibers, bilateral facial and abscess paralysis with intact oculomotor nerve. This is what is called locked-in syndrome. Infarct of the ventral midline pons. Ventral midline pons, wherein pyramidal fibers of both sides are affected and the descending facial nerve and the abscess nerve during its course at the pontomedullary junction. It is at this part of the pons the infarct is located, which involves the pyramidal fibers of both sides and the facial and the abscess nerves of both sides. Okay, but oculomotor nerve is not at this level of the brainstem. It lives, though it is ventrally located, but it is at the upper border of the pons or lower border of the midbrain. So oculomotor nerve is not affected. So what I mean to say is, if you know the neuroanatomy, it's very easy to interpret the clinical presentation of the neurological symptoms. Well, this is the area of the infarct, the locked-in syndrome. This is bilaterally involved. This is another one. Where is the facial colliculus? What is it? This is the location. This is the facial colliculus located just ventral to the fourth ventricle. It is located in the floor of the fourth ventricle. This is the facial colliculus. In fact, in this area, results in the facial nerve palsy, and you get the loss of taste sensation, and there could be hyperacusis. Well, thank you very much, my dear students. We'll conclude the talk and see you in the next class. Until that time, bye bye and take care.